Hello, everyone. A very good morning, good afternoon, and good evening to all the viewers who is tuned on to this webinar. This is a IME webinar series by WSPOS on the myopia management. Today's talk is a closer look at the pharmacological modulation, pupil modulation, and behavioral changes. This is an independent medical education. The support is provided by Essilor-Luxottica at the gold level, Hoya at the silver level supporter, and also we have Cooper Vision on the bronze level supporter. In India, today is celebrated as a National Doctors' Day. So a very happy Doctors' Day to everyone. When I say doctors, I think people just relate it to only the physicians and surgeons. I think in the eye care, there are many healthcare professionals, doctors, optometrists, orthoptists, and who help us with technology, pharmaceuticals. Everybody is involved in this care. A very happy Doctors' Day to everyone. WSPOS Education Forum, you all can view it in the forum.wspos.org. It's a very good resource for evidence-based educational programming features, which has symposia, webinars, video interviews, podcast, e-learning, and supplements. And I request all of you to go through this. If you haven't, there are a lot of educational material. Today's faculty, we have a diverse range of faculty from far east to far west. I am joined by my co-moderator, Mark Bullimore. He is an adjunct professor of University of Houston College of Optometry. And then Dr. Rupa Wong. She is a pediatric ophthalmologist at Honolulu Eye Clinic and John A. Burst School of Medicine, unit of Hawaii. And then we have Dr. Audrey Chia. She's a pediatric ophthalmologist at the Singapore National Eye Center, and she's also co-head for myopia research at SERI. We are also joined by Dr. Ian Flitcroft. He's a pediatric ophthalmologist in Temple Street Children's Hospital, and he's a PI for multiple myopia management trials at SERI. That's one more SERI, Center for Eye Research, Ireland. We are also fortunate to have Dr. Jefferson Doi. He's a pediatric ophthalmologist and genetic eye disease specialist working at Wilmer Eye Institute, Johns Hopkins, USA. And last but not the least, we have Dr. Jara Rashid. She's an optometrist working in private practice at Gertrude's Children's Hospital, Nairobi, Kenya. So we have a fantastic group of faculty today. Thank you everyone for joining us today. Today's agenda is a bit packed. It's everything about pharmacological pupil modulation, and we will have some of the audience response questions and also a good time for panel discussion. I would like to bring your attention to this quick response code to access to the audience response questions. There are two ways to do it. You can scan this QR code here, or else you can type www.menti.com and use this code 47011788. I'll just give 10 more seconds for people to scan or enter this code 47011788. I hope everyone have joined this menti.com. And the first question, it'll appear on your browser, is where do you practice? Europe, Africa, Middle East, Asia Pacific, Indian subcontinent, North America, South America, Australia, New Zealand, and others. please type in your responses there.
We're getting responses streaming in there, Ramesh. So people are responding as you requested. And the QR code is the same for all of these questions we're going to ask, and people can actually just click to the next question if they're sitting there bored already.
This is the next question. How many pediatric myopia patients do you see in your clinical practice each month? Response A, 0, B, 1 to 10, C, 11 to 20, and D, 21 to 30, and E, 31 to 40, and F, yes, some of us will be seeing more than 50. So type in your response. That's the second question. I'll be showing the answers for this response very soon. You will all know this. We have 3 sets of audience response question. And the last question is, how strong is your understanding of the latest treatment options for myopia management, including atropine and behavioral modifications? Very strong understanding, moderate understanding, and little understanding. And the last response is no understanding. So I'm sure none of you are at E. So please type in your response, and we will learn more about this today. Thank you so much. I will stop here. I'll stop sharing. Now I request Dr. Audrey Chia to speak about best practices in managing myopia progression with atropine. Over to you, Dr. Chia.
Hi, so thanks very much. Can you hear me there? Is it okay? Yes.
Would just request you to go to the PowerPoint full presentation mode.
Okay, let me do this again. Is it sharing now?
Yeah, it's good.
Okay.
Go ahead.
All right. Okay, thanks very much, everyone. So I've been tasked to talk a little bit about best practices. Let's see. So in the topics I was asked to cover is different perspectives, when to implement it, and the approach that we've developed in Singapore on how to monitor the treatment. And these are my disclosures. So a little bit about atropine. We know that we started using it or was considered as a treatment for myopia progression as early as in the 1970s. And in Singapore, we've been using it in our clinic since the early 2000s. And in the beginning, we're using 1% atropine. We started using 0.01% since 2014, started 0.125 since 2017, and just recently started 0.025. So we know atropine is a non-selective muscarinic antagonist, and I'll leave it to Jeff later on to talk a little bit about the mechanisms of how it's worked, but we do have a little bit more understanding now than before. So in terms of what atropine and how to use it, I think we need to know a few things about how it works. Firstly, we know that there's a dose-related effect of atropine, so that higher doses work better than lower doses or have a stronger effect than lower doses. So you can see the difference in range. And in the lower doses, we also now know that there can be a difference between the effect on spherical equivalent and axial length. So it's quite important if you're using lower doses to try and monitor both if you can. For the clinician, it's easier to think about it as what is the mean change when you use each of these different doses. And for example, with 1% atropine, we're talking about in a year, maybe 0.14 to 0.15 diopters, about a 0.14 millimeter increase. And in the lower doses, it was like say 0.01%, you got a range that goes from 0.2 in the ATOM 2 study to in the LAMB study, which is a population that includes younger children of 0.59 or 0.6 diopters and 0.36 millimeters. But these are just means. And if you look at the patient when they come in, there's a wide range of responses that can occur. So sometimes when you start a dose, although you know what the mean is, the response can be a bit unpredictable. We do know that you get a poor response if the child is younger their higher myopia or their family history of myopia, so that in these children, we might think about using higher dose from the start. And even in very high doses of atropine, we know that in 10% you might have a poor response. The side effects also follow the doses, more side effects with higher doses than lower doses. So for the 1% atropine, you almost always need to provide progressive glasses and tinted glasses. In the 0.1, usually in the Asian population, Chinese Asian population, it's 50-50. Sometimes you need these glasses. And in the very low doses, often children don't need any progressive or tinted glasses. But if they do have an effect, it's more likely to be glare than blur. So they might need that tinted glasses if they do have this side effect. We also know that when you stop it suddenly, you can get a rebound, especially for higher doses and in younger children. So there are a lot of RCTs now, and this is just a range of the different doses and the change in spherical equivalent and axial length over a 1 year period. And in comparing the studies, you just need to realize that they include different ages, myopic ranges, different sort of formulations and stuff. So there are differences in terms of the response sometimes. But there is still that dose-related responses. You see that the response gets better with higher doses. But even within each dose, there's some variability. And even the placebo in these studies, you can see quite a wide range. And the response may be better in some populations than the other. We know that in the WA study, the Caucasian children did better than the Asian children. And in Sharma's recent paper, the Indian children did quite well. But of course, I think we need more studies in different populations to understand this effect better. So when do we start? We start when there's a documented change of myopic progression, and we can depend on past refraction of axial length if available. But we need to be aware that sometimes there are other causes of myopia that might be non-axial, and we must be a little careful starting suddenly if we're not sure it's these causes. So it's sometimes nice to have a 4 to 6 month monitoring period if you can. We like to start when there's high risk of progression, especially early onset myopia, younger children, again, family history and family history of complication. So depending on what you start, depends on what you have available, what's affordable in your country and what's sustainable. And these might be different doses of atropine and might be other treatments. So for example, in Singapore, we also have multifocal contact lenses, OK lenses, and glasses. We normally use the DINS and Hawk glasses. Certain eye conditions may also limit your choice of what treatment you choose, and also parent and child preferences may also play a role. So in terms of atropine, what we normally do really, in my mind, when we see a patient is I divide them first by age, younger patients, older patients, because I know younger children behave differently and might need more treatment. And then I also sort of like segregate them in terms of risk. So let's say you have a very young child of less than 8 years old, and they first come in and it's the first visit and they have very, very low myopia. So the question then is, do you want to start or not? So you might at that stage tell parents, okay, we'll monitor with good eye habits to try and limit progression. And but in some cases you might want to start a low dose atropine. And normally in our practice now, we first line is 0.025%. And the older child, again, we might want to monitor, but we can also start low dose atropine, and here we can use a wider range depending on what parents prefer. And we can also consider contact lenses or glasses, but usually it is very low myopia. Sometimes they don't need contact lenses or glasses, so it's quite hard to start that treatment. More commonly, we see the children of average risk, the ones that come with some myopia and some progression. And if they're young, then we might start the low dose atropine, again, either 0.025 in our population, but whatever you have. You might want to try contact lens, glasses, or combo. But contact lens in young children, sometimes the parents are a bit worried. And the glasses effect in younger children is sometimes not predictable too. So sometimes we may start on the eye drop and then hold the other treatments for later. But when you get an older child, more than 9, then you can do anything. You can have any option that you want, depending on their whether it's suitable for them or not. When you get a very high risk one, and these are the early onset, really high myopia, very fast progression, then you want to start something quickly. So in the less than 8, we will start on the low dose atropine first and see how they go. But we will be very prepared to go to high doses when necessary. And sometimes we might even try combo if the parents are willing. And sometimes some of the other treatments are quite expensive. So it's a discussion with parents whether they want it or not. In the older child, we can do combo agents, usually low dose atropine with glasses or contact lenses, and we can increase the atropine dose as necessary if more response is required. In terms of monitoring, we just start when they're unstable and normally follow them about 3 to 6 months. And when they're stable, we go up to about 6 to 9 months. We usually try to do an annual cycloplegic refraction, but we can do it anytime if we want to. And we're depending a little bit more on axial length now because it's a lot easier. But this is not available everywhere, I realize. So it depends on what you have. And we want to target axial length and spherical recurrent. We want it to be less than before. And in the younger children, we know that they can have more progression and more increase in axial length. These are roughly Singapore data, would differ in maybe the Caucasian populations would be much less. So we get about a 50% response, we might be happy. And in the older children, we're expecting less progression and axial length progression. So we also target for a better response. In terms of stopping, usually in the younger children, less than 12 years old, if they've been stable on treatment for about 2 or 3 years, I consider very slowly tapering it, and then doing a more quicker taper if they're more than 12 years old, if they're stable. And ideally in Singapore, we hope to get them off by mid-teens. But I know in some countries and in China, because of exams in late teens, they want to continue a bit longer. So this is an example of how we used to use 1% atropine in the early days. So this is a child. I'll orientate you. We have on the y-axis the spherical equivalent, the myopia increasing over time, and on the x-axis time, and each of the little boxes are 6 months. The crosses are the right eye, the circles are the left eye. So we have a child of 8 years old. It's around about 400, 500 diopters, and we start them on 1% atropine 3 times a week. You can see the hyperopic shift that occurs on high-dose atropine. At about a year, we cut it down to 2 times a week. There's some rebound, and then it stabilizes. Then we cut them down to 1 time a week after a year, and then after a little while, and then the 12, I cut down to every 2 weeks, and then stop. And then we just monitor it for a little while to just make sure it's stable. This is how we would use 0.01% atropine. So this is a child that came to see us when about 9 years old. But we know there's documented progression from the past glasses. And here we have axial length data as well as spherical equivalent data. And so we start atropine, we watch, and we can see that the axial length progression is reasonable, and we continue it. And as they get older, after 12, I taper it. And when it looks as if it's monitor. Did I lose anyone there? You still got me?
Yeah, it's just that your presentation is, you stopped sharing.
Yeah, okay. All right, okay. It's connections a bit. Okay, so can you see the slide again?
Yes.
Okay, right. So this is a child that's treated on 0.025%, 8 years old. Has also got a squint. So when we start, we can see that sometimes even in the same patient, you get an opposite response. The right eye is going well. In fact, you get a hyperopic shift. In the left eye, it's actually increasing. The last time I saw it last month, it looks as if the left eye is still increasing, but because the axial length change is not much, I've just continued the medication, and then we'll probably continue until he's 12 and then slowly taper. This is another child which we see. The child has come in when it's about 4 years old, but there's some documented past refraction that is quite low, and it looks as if the myopia has increased a lot. In this case, because the reading was not done by us in 3 years old, we're not sure it's real or not, whether it's stable or it's going up. So on discussion with parents, it's earlier days of 0.01%, we started it every other day just to have something on board. And it looks as if over 6 months, nothing changed very much. So we just continued that, and then there's this increase. So we went to daily, and it's still increasing. You can see over this 1 year period, it's actually gone up about almost 1.23 millimeters. So we started the trial on 0.125% every other day. There's some reduction, there's still some progression. So we go to daily, and we're watching the axial length again. One eye is doing better than the other. And here we have at 8 years old, just pre-COVID, the child's now been on 2 years. It's progressed about 0.2 over that time. So quite happy with this result. And the child has unfortunately lost to follow-up during COVID. I hope she's been seen somewhere, but usually we'll just continue this a bit longer and slowly taper it off when she's a bit older. So in terms of using atropine, there's some general principles that guide our choices of when to start treatment, how to adjust treatment, and normally it's to increase frequency or dose or decrease frequency or dose, and using combination treatments is necessary. And normally I taper rather than suddenly stop, and hope to be the child off atropine in their mid to late teens. Thank you.
Thank you, Audrey, for that brilliant overview and a lot of pioneering work, what you have done during your tenure there, and you're still continuing. Thank you so much for that. Now I'd call upon Ian Fitcroft to talk about do concentrations, preparation, and dose of atropine matter. Over to you, Ian. As he is loading his slides, there are many people have joined across the world from various parts, from Poland, Indonesia, Slovakia, Italy, Japan, Greece, UK, USA, India, Chile, Argentina, Spain. So many people have joined today. Thank you so much for joining. And over to you, Ian. Thank you.
Okay, my slides showing out there?
Yes, thanks.
Oh, great. So I'm going to start where Audrey left off, but look at some of the details and perhaps some of the wrinkles about this topic. In terms of disclosures, I'm working with a range of companies, both pharmaceutical and optical, and most notably by Luma, and also have interest in a data analytics company from my university. So there are lots of unanswered questions, and we haven't got much time in terms of concentration, formulation, ethnicity, and color. So we're going to skip through this reasonably quickly and hopefully have time during the discussion to explore some of these practical aspects of these questions later on. So just taking on from a topic that Audrey mentioned about efficacy, the dose-response effect of atropine and the fact that atropine seems to be top of the pile, I think was sort of first defined graphically in this sort of way in a study I was involved with in 2016. Now, the world has moved on very, very fast, and this is probably the most recent meta-analysis, combines both studies and case series, so not quite as clean, but appears to show a really sort of clear dose-response effect. This is a forest plot that's familiar with, so that the top panel is the high doses, 0.5 and 1%, and that triangle is the effect size. This is axial length, so this is in millimeters. And we see there the intermediate doses that Audrey's been using, and then the low dose was having an effect. Now, the story about what dose to use got interesting and perhaps complicated with the LAMP study that came out a few years ago. Again, showed a really beautifully clear dose-response effect on axial length, as we see here, with the grey one being a placebo effect and the lowest dose, atropine 0.01%, having an effect, but a very small effect. And then after a year, they moved across. And at each time interval, they were demonstrating that 0.05 was the most effective and a very low level of efficacy compared to Audrey's ATOM2 study in atropine 0.01%. And this led to various statements from one of our moderators, looking at the point of view that that 0.01% atropine does not affect axial length in quite sort of clear statements. What is perhaps odd for me is that sort of analysis didn't change people's enthusiasm for it. It's still widely used. Now, the dose-response effect has seemed gloriously sensible and logical, just got horribly sort of illogical with the results of a study which I've been involved with, and this the CHAMP study, which is a large North American and European study, compared the efficacy of 0.01% and 0.02%. So the question, first of all, are we seeing a significant, at least statistically, effect on axial length in a European population at 0.01%? And that's the graph on the left there. The answer to the question is yes. And same thing on refraction. I think it's fair to say these were less than we might have hoped for. The real fly in the ointment here was that we actually saw a less significant effect in 0.02%. Now, the other European data that's just come out the same year is Irish Mosaic trial. My colleague James Lockman and I have been running this out of Surrey in Dublin for the last few years. Now, this trial was started pre-COVID. We enrolled most of our people and then were exposed to quite a rigid homeschooled lockdown in Ireland. And the second half of the trial were recruited after the school closures finished. And in effect, we saw two quite contrasting differences. Those who were on treatment mostly during homeschooling education on screens showed no significant effect. And those enrolled post showed a rather typical familiar-looking graph of efficacy in both axial length and refraction. Now, I think this comes to a point which is really important practically, is that good treatment and bad behavior is probably not good enough. And as a point I'll make at the end, just writing prescription, thinking your job's done, may be false reassurance to oneself and for one's patients. Now, when looking and analysing, comparing these studies, a big issue that we became familiar with when we started our trials was how to get atropine in a stable formulation, and it's not trivial. And all these studies are compared in meta-analyses with the assumption that 0.01% is 0.01% and 0.05% is 0.05%. But when you look at the biological comparability, the pupil effect in Audrey's Atom 2 study of 0.01% was pretty much the same as LAMP's 0.05%. The recent study a couple of years ago with very carefully sort of validated atropine concentration at a very low pH, which is very important because it makes it stable, versus the LAMP 0.05%. Now, the placebo for that was normal saline. So I can only presume that the vehicle was also normal saline and hence much more neutral in pH. But that European pupil effect showed a dramatically bigger difference of 4.2% versus 2.4%. So that raised suspicions that the what's in the bottle may not be what's on the label. And Mark's very, very nice paper that's just recently published looked at compounded atropine and showed a huge variability in terms of composition, pH, preservatives, and the fact that the concentration often didn't match, not to mention other contaminants. So the big issue with atropine in practical use is the fact that it's compounded, and what you actually see in the bottle may not be what you think it is, and therefore relating that to published evidence can be surprisingly challenging. So if we look at the LAMP versus the US European CHAMP and just look at refractive change versus axial length equivalency, the CHAMP studies are in the yellow there, different concentrations. So it's only for axial length, for example, the CHAMP is closer to the 0.025% in the Hong Kong version than it is the 0.01%. Now, as already mentioned, there is definitely a link with younger kids will often show quite a marked progression on treatment. And this shows from the LAMP study the impact. And even at the highest dose, which is their most effective level, you're still seeing sort of quite eye-watering levels of progression. And as one of the talks later on is looking at the genetic causes for this, I'm a strong believer that these young patients have a very different sort of set of etiologies, and some of these are definitely genetically driven and have faster drivers. And some of those, at least, may not be amenable to atropine, but I think we're covering that topic later. Now, eye color is an obvious one because Audrey's patients have very similar color eyes. My patients have mostly blue eyes, but a lot of variation. So in Mosaic, we looked at this question, and it turned out to have a rather interesting answer, which is that we were finding that the blue eyes were significantly more effective for both progression and axial length. And actually, we did not get an effect on brown eyes. In fact, they're the wrong way around. The treatment ones were progressing a little bit faster, peculiarly. There was other complication in this area is that we're seeing a slight disconnect of the side effects and efficacy. Now, the side effects in Europe, we didn't need any bifocals in our group. We are in our final year now, flipping over to 0.05%. This is the first European population that's been exposed to that in a controlled trial, and we'll have results for that in later this year. But we're now starting to get near vision issues need correcting. In CHAMP, the pupil effect was biggest in the 0.02%, but the efficacy was lower. And we're also conducting another study called TOAST, which will be again published later this year, certainly will be available for publication later this year, where we were looking at sort of eye color, concentration, and dosing regimes. And despite the fact we were getting higher efficacy in blue eyes, we're getting more side effects and more dropout in the brown eyes. And I think I have a theory about that, which maybe we can come up in discussion. Now, in terms of the acceptability of CHAMP and European studies, one thing was quite clear, that this is very well tolerated, and in terms of eye irritation, photophobia, and blurry vision, very, very low levels in that study, with no significant difference between the groups. Now, it's fine to sort of pontificate about sort of trials and things, but I just want to summarize a few sort of practical points that may be relevant to individual practice. That outside, so Myopine is available in the Far East. It's not available licensed in Europe or the US, as far as I'm aware. So most preparations people are using are very variable. So just writing prescription, letting your patient walk out the door and thinking you've done a good job is an assumption which may be incorrect. So effectively, in any compound situation, atropine is an entirely empirical activity. You can see the evidence, but you don't know if your patient is going to match that. As already pointed out, because of that, even more so, we absolutely have to very closely monitor axial growth on the basis that that may be a biological effect of a patient not responding, or a pharmacological effect that we have an ineffective preparation. The pH and preservatives, so Myopine pH is around about 4.5, or you might correct me on that, and with benzalkonium chloride, there are other higher pH ones, some compounded are close to neutral. That means that preparation will be unstable. Our study has shown that just writing prescription and saying nothing is probably not adequate. So myopia management is not providing a myopia control treatment, it's actually managing that whole patient, and behavioral modification appears to be, certainly in our trial, very critical. As already pointed out, we're getting to the point where people are starting to customize regimes, and the highest tolerable dose is certainly the one that is a perfectly good strategy, with younger fasting being high concentrations. One of the questions that was put in the initial scope was that, what do you do if low-dose atropine isn't available? And it isn't licensed in Ireland, and because of my concerns about preparation and compounding, I use something which already uses in a tailing thing, which is the 1% on Friday nights. The reason by Friday nights is by Monday morning, their accommodation is actually back in an adequate regime. They may require very focused for weekends, but most of the time they're not at school. That works really well. And if you use minims, that ends up being probably the cheapest, most cost-effective solution that I can get my hands on. It's my go-to salvage therapy. Now, in terms of oculomotor side effects and blurring and binocular vision, a lot of words said about that, and the fear of annoying people into the BV camp. I think the infrequency of those events means that it's important to warn patients. Low-dose atropine increases the ACA ratio, but it can certainly make esophorias work, and there are case reports of that. So I just do a near cover test and near vision reading, and I regard that as and tell patients, and that seems to be sort of enough from my perspective. On that, I'll leave that, and hopefully we can pick up the other comments of this during the questions.
Thank you, Ian, for that wonderful presentation. I think we have few questions. Start with Mark. Yeah.
Yeah, thank you both for really great and informative presentations. I have a couple of questions. You mentioned the need to follow up patients to see how things are progressing. How soon after initiating therapy do you like to see the child? I'll start with Audrey.
Yeah, so if I'm very uncertain, like the child has very high myopia and things, I see about 3 months the first visit. However, in Singapore, if there are, because our school holidays, big periods are 6 months apart, sometimes the parents say, oh, can I come back 6 months? So if they're lower risk, I sometimes see them in 6 months' time.
What about you, Ian?
I stick to 6 months on the basis. If I saw them in 3 months and it wasn't quite right, I'd probably sit on the fence for another 3 months anyway. So I just save myself and my patient's time and goes six months. If after a year or two treatments, things are ticking along pretty well, I will just drop them down to, once a year. But that just reflection of, pressure on my clinic rather than an ideal practice. But I think 6 months is not too late as a regular monitoring thing. I think some Audrey's graph shows that it's not always a nice, flat, predictable curve. So I think 6 months is a good time.
Yeah, and I assume you have to pay attention to seasonal variations in progression.
Not in Singapore.
In Singapore, there are no seasons, but and with Ian, he's dealing with rain all the time. But
we have no summer. So I mean, the patients come when the patients come. So, but you are taking a slightly sort of longer term view. So, I mean, I'm not going to likely to change treatment, within a year. So, one swallow doesn't make a summer, and one leap doesn't make an unresponsive child or responsive.
The other question I had, you both sort of either showed cases of very young myopes or spoke about the need to sort of perhaps treat them differently. What are the alarm bells that ring for you when you've got a young myope and you think, or you want to exclude some more sinister etiology? Audrey, what do you do?
Well, the things that worry me is that the vision doesn't correct to 6/6 or 20/20. If they got any sort of lens problem or whatever, high K reading and things like that, and if the axial length doesn't match the spherical equivalent, so those sometimes are factors. And of course, the main thing that I want to exclude is glaucoma. So then we're looking at pressure, optic disc, and to see what is. And sometimes I have cases that they're very young and you look, oh no, the CD ratio is around about 0.6 and the pressure is hard to measure. And it does, you just have to just monitor a bit. And sometimes if you really need to, you take them to theater and measure it under sedation.
Ian, you want to add something? Maybe put in a plug for your recent IMI paper?
Indeed, the IMI just published a paper which Audrey was also involved with, where we've looked at this exact question, with a flow chart. And so, I mean, as one simple one that Caroline Claver came up with is that, if a kid has more diopters than years in their life or candles in their birthday cake, so, a -4 3-year-old or a -5, 4-year-old has alarm bells. But we go through and list, there's a couple of high yield questions for the family history, any family history of, cleft palate, deafness, a family history of someone who's had a retinal detachment is also, they're good high yield questions for some of the syndromic forms, and a prior history of heart valve surgery. You have to ask that gently, not to alarm people. And then for the kids, I think the non-corrected best visual acuity, as Audrey said, is a really sort of strong one. Then we recommend in that paper, just moving to, if there are clinical or history risk factors, you need to go down the investigation path from a structural point of view, and then potentially from a genetic point of view as well, because some of the diagnoses are more important than myopia progression. Because with Marfan's, you may be the first person diagnosed in that family. Okay,
well, we got a Marfan's expert coming up in a minute, and I think we probably need to move on. But just one question before we do. Ian, how many of your kids who are on the Friday night special 1% need any sort of progressives or photochromics?
A It's depending if they do sports. The sporty ones sometimes do for the photophobias, the skulking gamers don't. I actually start with optics first and pharmacology second. So most of my kids would be in a multifocal contact lens, which provides enough reading support. So they manage. So just the way I sequence it, it's a failed optical, gets an atropine on top, and then the failed optical actually is the reading end.
Okay, we'll come back to the hierarchy. Ramesh, shall we move on to the next presentation?
Yeah, we will move on now. Zara, we'll come back to your question. I know you're making a point there. So the next question is, the next presentation is on the most interesting aspect. We have used liters and gallons of atropine from many years now, but still the mechanism of action of atropine, we are still not very sure. So I would request Dr. Jefferson Doyle to throw some light on clinician scientist perspective on atropine. Over to you, Jefferson.
Thank you so much, Dr. Doyle. Ramesh, what's your pleasure here? Do you want to move on to our next presentation, or are there any questions from the panel?
Yeah, we could take just one question and then move on. That was a brilliant piece of basic science work, Jefferson. Really enjoyed it. Can you extrapolate this data to, to other monogenic forms of syndromic myopia? And also, I just wanted to know your comment on myopia related to retinopathy of prematurity.
Yeah, wonderful things, and actually, other questions we're actually looking at the moment. So we have nice, really robust phenotyping in at least one model of an inherited retinal dystrophy, and so we're looking at the impact here. I think it's an intriguing question with both the retinal vascular development as well as the dystrophies. To ask the question, is the myopia, is it a cause or contributor to progression of the degeneration? Is it a consequence, or is it simply coincident? And obviously, therapeutically, when you manipulate one, what effect it has on the other. So I have to concede I've got many questions, not many answers yet, but we hope to have them actually pretty soon.
Thank you. I think we'll move on. Next talk is a recorded talk. Dr. Rupa Wong. She is in far west. She's in Hawaii. It's beyond midnight now. So she was really gracious enough to record the talk and send it. Let's play her talk, followed by we'll have a talk from.
Hello, everyone. I am Dr. Rupa Wong, coming to you virtually. And I know I only have 7 minutes, so let's get straight into it. I am a pediatric ophthalmologist out here in private practice in Honolulu, Hawaii for the last 15 years, and I'm a huge advocate of myopia control in my patient population. Here are my financial disclosures, and this is my why. This is my husband. He is an ophthalmologist as well. He is cornea and refractive surgery trained. He's got a lot of great qualities. One of them happens to be he's a high myope. He has axial lengths over 28 millimeters in each eye. That is not something that I wanted for my children. So I became someone very passionate about myopia management, myopia control. And that's how I am able to create parental buy-in with my own patients. Parental buy-in. How do we overcome parental objections? How do you convince them? How do you sell to them? Well, first, we're going to get rid of that notion. You're not convincing parents. You're not selling to them. What you are doing is educating at absolutely every single opportunity. And then you're overcoming their objections and pain points even before they are able to verbalize them to you. And I'm going to go through that. Education. I think the more that we can educate our patients' parents, the better. So most of the times, one of these parents is myopic themselves. So they're slightly familiar with the added risk that their children carry for nearsightedness, as well as all of these lifestyle risk factors that I always go over with each and every single patient. Most parents are very worried about the effect that distance learning had on their children. This is a little TikTok I had made with my then 6-year-old in the middle of home confinement. And you know that great JAMA ophthalmology article, we've got great data and parents, they're aware of it. They are reading these articles. So the education, the foundation is there, and all we have to do is present more information about myopia and nearsightedness so that they can make the best decision for their family. I also review the ocular health consequences because, as you all probably do, I tell the parents it's not about how thick the glasses are. It's about preventing long-term vision-threatening eye health complications, things like myopic maculopathy, retinal detachments, cataracts, and glaucoma. I make sure they understand that if their child becomes a high myope, that they are at additional risk for these things. And then I do as much as I can to give them the information that they need. I created these folders myself. I just made them on my computer, print them locally at a shop. And I utilize protocols so that every single patient gets this folder. Every parent gets this folder, whether or not they have decided to institute myopia management treatment strategies for their own child. I want them to be educated. So it goes through all the different facets. What are the eye drops? What are the contact lenses? And then the research behind it. I include 4 to 5 articles, the LAMP study, the ATOM study. It's all in there, outdoor time. I want them to know what they can do that's free, that will also slow potentially their child's nearsightedness. I think a lot of ophthalmologists and optometrists are concerned that this education is going to increase the chair time. And they're already stretched thin and working too hard and very busy. And that is not necessarily so. There's a lot of things that you can do before the patient's even in your exam room to educate. So I mentioned social media before. I also have, this is on the left side is my website. I have all of this information that's in the folder on my website. My receptionists know that as soon as a patient's parent calls saying that they're worried about their child's glasses or a failed vision screen, I direct them. We send them this link so they can read through at their leisure information about myopia management. In the Coral at the bottom, we will drop a box of all the actual articles that they might be interested in. I also created an online quiz, which helps risk stratify based on how many hours a day their child's outdoors, how much near time they're doing. Everything that you can do to educate, that's going to create the parental buy-in. This is a little video I made with my daughter. You can check it out. It's on YouTube under my myopia playlist. And this just decreases the anxiety for both the parents and the child, because my daughter is talking through exactly what is a myopia management visit. And watch her for a second, because this is pretty funny.
Because you are interested in myopia.
My patients love this. They think she's hilarious, and it decreases anxiety. Second, overcome their objections, even before they're able to verbalize it themselves. So most parents are concerned about safety, efficacy, administration. How are they going to get those drops in? And here in this country, cost. Again, reviewing all the studies so that they know here is multitude of years of data. This is how safe it is. This is how effective it is. That's my middle son there. And then I personally will use the fact that my children are on it. All 3 of them are on it. They are pre-myopes, and I wanted to keep them that way. I wanted their axial lengths to stabilize. That's my 13-year-old, already approaching my 6-foot-tall husband's height. This is why I love data. And I do axial lengths every 6 months for my patients. I print out this graph and I give it to parents so they can see it is treatment. Low-dose atropine is treatment that is effective. Look at this chart. This is my son's again. Amazing. And then administration. They don't want something that they're going to have to fight to put into their children's eyes. I go over tips and strategies. Again, I made a little video with my daughter. Anything that you can do to show them it's not so difficult. Create a timer. Go through those strategies. Are you going to forget it? Put a strategy. Put a timer on your iPhone so that everybody knows to put the eye drops in at nighttime. I go through all of those tips and tricks in the office. Now let's talk about combination treatment. I have a couple of patients. I have probably about 15 to 20 patients on combination treatment of low-dose atropine with a MiSight contact lens. I do this for patients who are progressing higher than expected, specifically with their axial length, not just their refractive error. So I thought I would show you a case that we had in our clinic. She was 11. She is half Chinese, which I think is important in terms of risk stratification. Worsening vision despite the use for glasses. You can see that her prescription had increased from the previous year. So we had a discussion and started her on low-dose atropine. At that time, I was starting everybody on atropine 0.01%. I now start everybody on 0.05% and titrate down. So this is her spherical equivalent before atropine, minus 225 OD, minus 275 OS. And then we started the low-dose atropine. She's still getting worse. And her axial length is specifically still progressing, over 0.55 millimeters per eye. I had discussed with the parents about increasing the strength of the atropine, going up to the 0.02 or 0.05, but they didn't want to because she was doing a lot of outdoor sports and they were very concerned about the photophobic effects. So the nice thing is finally in 2020, when the MiSight contact lens got FDA approved here in this country, then it was something I could offer her. And even though she had been in a soft contact lens, we then switched her out to a MiSight contact lens. As you can see here, the right eye at 550, left eye 5.25. Full discussion about the off-label use. And then here are her measurements, her refractive error and her axial length. Still progressing, of course, but much more stable. Now you might think, well, she's already 15. You're not going to see that much of an axial elongation. Of course, we have all of those patients where they still do. And she was clearly a fast progressor. So I consider this a win. These are the kind of patients that I reserve combination treatment for. Sometimes I do have very patients that are concerned. The parents are concerned because they're minus 13 or minus 14. In that case, sometimes we do start right off the bat if they want to be very aggressive with treatment with a dual action of a low-dose atropine with a MiSight contact lens. But of course, there is not a lot of prospective research out there, hardly any studies at all, and specifically not a lot of studies in Asian children. A couple of studies I found in Jerusalem and Caucasian kids. More data, we need more information. There are no specific protocols. It's more of an art form, and I do it on a case-by-case basis if I note the progression is worsening despite treatment. If you have any questions, please feel free to reach out to me. On all these social media platforms. I got a podcast, I've got YouTube, TikTok, Instagram, I've got it all. And you can also send me an old-fashioned email as well. Thank you so much for your time.
I think that was a wonderful talk by Rupa. We at WSPOS also has a consensus statement for parents, which is a short one and also a longer one. Parents can download it, and even the pediatric ophthalmologist or healthcare professionals can give a printout to them. So the last talk for today is by Zara Rashid. She's going to talk about effective behavioral changes that help to slow myopic progression. Over to you, Zara.
Can you see me, Ramesh?
Yeah, we can see you and hear you. And go to the presentation mode. Yeah, perfect.
That's it. Perfect, great. Thank you very much. I'll just go straight onto it. Great. I think I moved too fast there. Just one more. Sorry, I'm going to I can't seem to see my first slide. I'm just going to escape that and start again. Okay.
We were able to see it.
You can see the presentation there? Great. Okay. So in terms of, I have a small clinic based in a children's hospital, and based in Kenya, we have very little access to different types of myopia prevention strategies. But what we do in our clinic is that every child that comes into the clinic, every parent, we actually start myopia prevention right in the waiting room. We see various patients for various eye conditions, but that's our opportunity to start. So we will see parents, and they will come as families, and many of them have been coming to our practice for many years and at the children's hospital. So it's a good opportunity. Many of them, will come in with their babies, but they've got maybe a 10-year-old at home. And when they see all the material on myopia prevention, they start to ask questions. And that's a really good starting point right in your waiting area, where they, parents can be educated as well as their siblings and grandparents as well. We get a lot of questions from grandparents. So we really target a lot of the high risk patients. So those are usually your younger patients, your 5 to 9-year-olds. And then those who already have parents with myopia, And of course, every child that walks in, we do a refraction, we do a retinoscopy. And if you look at their expected age and you think, okay, this child isn't as hyperopic as they should be, you're already starting to talk to the parents about behavioral change. And of course, specific ethnicities as well. So most of the time, we're talking about how much time all our kids should be spending outdoors. And we do this education not only in the clinics and in the hospitals, but we also do it when we go out for school screening. So we're constantly educating the teachers as well, especially the kindergarten teachers. As soon as they start going into almost grade 1, we're already starting to get them, to educate the children, talk about screen time. Nowadays, we're seeing children as young as, maybe even 6 months to 1 year old. Parents are walking into the clinic, giving their children screens. So it's really, really important to keep emphasizing the importance of, spending time outdoors and how they should spend less time indoors, and the studies that we've done and seen the effects over during COVID as well. But I think the message we give out, initially we used to all say, screens are bad. But the message to the parents a lot of the times is we say screens are not bad. The trouble is that we don't know how to take breaks. We spend a lot of time, and sometimes, parents are busy, house helps are busy. They'll tend to give the kids their screens, even the house help we've seen, just so that they can get on with their work, and they will go back to the kids 3 to 4 hours later. And that's most likely what is detrimental. We're also educating them about, parents will ask you, what's worse? Is the phone worse? Is it okay? Can they use a television? Because parents are also keen to make sure that their kids don't get left behind. I think that's the question I get a lot of times, is that, if my child doesn't sit on technology, is not up to scratch with everything that's happening, are they going to be left behind? And that's a question we always answer every time we have that discussion with parents. And we now started to tell them that, look, even if you're learning online, can we use a TV? Can we project? Rather than having them really close up to the laptop for 6-8 hours a day. We're starting to see that mindset where parents initially are like, oh my God, this is something different. But as soon as you start talking to them, they start thinking, and every time they come back for visits, they always tell you what they've modified, what have they done that is different this time. And the other thing is to keep children busy. Parents say, we're really busy, we don't know what to do, and kids get bored, and now it's the holidays, the kids are going to resort to screens. But we say, look, try and have a structure, try and have a routine with all your children, and make sure that, you take them. I mean, there's some parents who actually take them from activity to activity. They take them from school and then make sure they go playing tennis, and after that, maybe they're swimming, so that, that structure is really important. And that's what I tell the parents, that, look, if you don't have a structure, if you don't have a routine, it's very easy for kids to get bored and then just resort to that screen that is available with them. So routine is really important. We also talk about lighting, that lighting is really important. Children shouldn't go to bed with their screens or reading or books with their lights all switched off, but to make sure that they have enough lighting. Earlier, I think you might have seen me, Ramesh, raise my hand. And, when we were talking about what are the other eye diseases that you talk about, we have a really high prevalence of keratoconus in Kenya. And unfortunately, because myopia control is so much, there's so much traction behind it that we're almost seeing many optometrists or even eye care practitioners not thinking about differential diagnosis. And my worry is that it could be a child that is actually developing keratoconus, but actually doesn't, because many of them don't do axial length. Many people in this part of the world don't have access to that kind of instrumentation, the optometrist. And it's now easy to get low-dose atropine. It's not regulated in this part of the world. So it's very easy for eye care practitioners, and as mentioned by Ian, is just to prescribe and then see the child after 6 months. And it could be 6 months to 1 year later when the child comes back and you realize, oops, I was on the wrong treatment. The child actually had keratoconus. I needed to send them for cross-linking, but now I've wasted a year and perhaps the cornea is a little bit thinner. So we're starting to see a lot of those cases. So my recommendations to, especially if you're practicing in countries where there's a high prevalence of keratoconus, and remember, we're seeing them as young as 5 years old. And I think we've seen studies in India as well. So it's really, really important to be able to differentiate. We use a protocol of half a diopter of progression per year to start low-dose atropine. We didn't have 0.05%. We've now just recently got it. So we are now shifting all our patients from 0.01% to 0.05%. I'm very particular about parents signing a consent form, and I'll show you one of the slides. I actually get parents, because it's very easy for parents to say yes, and they jump on the bandwagon, and then the compliance is really poor. You know, the child walks in, the child tells you a different story, and the parents tell you a different story. So when you ask, you know, do you put your drops every day? Mom is saying yes, and the child is, you know, shaking his head, and you're thinking, I've picked the wrong family. So it's really, really important to pick the right family, because if you're going to, you know, in terms of rebound, etc., that's usually my worry. I want to make sure that I'm going to pick the, you know, the child clinically may tick all the boxes, but if it's a family that's non-compliant, then I'll really hesitate to put them on atropine. Initially, I was very nervous when I started, and I've been doing this for the last 5 years. I used to see all my kids every 3 months. I'm now starting to judge which families I need to see every 3 months and which ones I need to see every 6 months. And so I will weigh it out. If progression continues, and I've seen it in a very, very small number of cases, I will then move to 1 drop twice a day. So this is a compliance parental consent form. So we've done a booklet, and families go away. We discuss with them. We have the verbal conversation. We send them away with the booklet. They get a chance to look at all the research. They then come back having signed this form so that they know what they're in for. And it's, you know, I tell them that this is a 3-year marriage, at least, if not longer. So you've got to be ready, and we've got to work together. I can't do this on my own, and neither can you do this on your own, but we've got to work to, you know, with your child, but you need to understand all these points. Come in and sign. And I find that those parents who do come in and sign, I then have their buy-in completely, and they're willing to work with us. So we send appointment reminders as well. Families are, you know, likely to be more compliant if we do this. I only give them enough bottles based on the number of months that I'm going to see them. So if I'm going to see them in 3 months, I will only give them 3 bottles. So that way I know. What happened is that if you give more, they don't come back for the follow-ups. Sometimes they'll come back to me after a year, and I'm like, you know, hold on, something went wrong here. So I've got to make sure that they only go in with enough. I educate the child and the parents just so that I get it all right. And sometimes the house help, because if parents are traveling quite a bit, I get them to bring the house help together. And that's quite common in our culture here in this part of the world, so that everybody is educated. And I keep reminding them about the 30-day rule, that you must throw the bottle after 30 days. I used to have patients who were using 1 bottle for two months. And then, I mean, we know it's not going to, you know, it's not going to be stable. So we've got to make sure, and I get the kids to make sure that they know how to label each bottle. We label the bottles here in the clinic so that they know they've got to start and end on this month, discard, and then start the next bottle. Of course, we reiterate at every visit. So, you know, exactly what Ian said, you don't just prescribe and they come for the visits. You have to keep reminding them. Parents forget, kids forget, and the constant, you know, spend more time outdoors, take complete, you know, lots of breaks from your screen time, and just get yourself activities that are mostly outdoors. That's it on my side. Ramesh?
Thank you, Zara. I think very valuable inputs in terms of behavioral modification. And also your caution about corneal and lenticular myopia. You know, people start this kind of therapy, which is really not good. And I think you also highlighted some of the issues, what can be there in some parts of the world, and some of the difficulties what we face. I think, Mark, shall we go to the panel discussion straight? Before that, I would like to invite you to 3 more questions. This is the QR code. And again, go to www.menti.com. The code for this is 18443096. That is 18443096. So you can access this scan or go to this menti.com and enter this code. So the first question is Atropine readily available where you practice? I think still in some of the places it's not available. If available, maybe some of the concentrations are not really available. Just 2 options, yes or no. The next question is, if atropine is available, what percentage you prescribe? Whether it's 0.01%, 0.05%, and 1%. And the last question is, if atropine is not available, that can happen in some of the places, what do? Do you use alternate drugs like cyclopentolate? Do you opt for natural therapies for the control of myopia? Do you compound it yourself? Or do you use optical therapies like TIMS, Halt lenses, bifocals, or orthocare, etc.? So these are the four options for that. So
We're getting some
share the results
responses.
very soon. Mark, over to you.
Yeah, just to give you a little update on the survey, about 25% of people who responded don't have access to atropine. Amongst those who do have it available, the respondents are fairly evenly split between 0.01%, 0.05%, and 1%. And in terms of if it's not available, what do you do? About half of the respondents are using optical therapies. About a quarter, somewhat surprisingly, compound it themselves. And another quarter or so opt in for natural therapies. So, so let's maybe ask the panel. Ian has already touched on this, but I feel free to have other people chime in here. What should practices do if atropine's not available? Anyone want to comment on that? And if not, we can move on to another question. Okay.
But just to chip in there, I mean, optics first is a that's an obvious, easy, low-hanging fruit if you have access to optical solutions. The big barrier to that is cost. So that's why I think on a practical scale, the 1% once a week is a good balance between effectiveness, reasonably low level of side effects. 1% once a day is intolerable, I think, for most kids. But the once a week.
Yeah, I agree with Ian. I think it's mainly a parental choice, and especially in the older kids that have the usual kind of myopia, and they sort of say what's available. And cost, unfortunately, is quite a big variable in our country, because the atropine is the cheapest, followed by glasses and then contact lenses. And I think there are very few places that are the reverse happens right now. I think in India, actually, it's not too bad. They're pretty much about the same. Yeah.
Yeah. North America is an interesting place because where I'm sitting right now in Canada, there are many effective spectacle options available. There are a number of contact lens options available, but you go south of the border to the US, none of the spectacle options that have been shown to be effective are available yet. And obviously, we only have one FDA-approved soft lens. Ortho-K is used extensively. In talking to my optometric colleagues, they're like Ian. They seem to go with optical therapies first and add atropine if they need to. I always say that the biggest limitation of atropine is that it doesn't correct the myopia. And one of the challenges I think that Zara alluded to is compliance. There's not an incentive or benefit for a child using atropine visually, whereas if they put in their contact lenses or put on their spectacles, they have the benefit of being able to see. So anything else to add in terms of availability of atropine?
Anybody? I just had a question. Atropine, if it is available, that's one of the cheapest option, along with the behavioral therapy for most of the people around the world, if it is available. But in some places, like 0.05% is not available. I just had one question for Audrey and maybe Ian. Do you use BD dosage instead of one time at night? Do you increase the dose to twice a day or something like that in these kind of situations?
Well, I do. So if you don't have any doses available, you can. I think there was one question I had once: can we use it 3 times a day and things? But that gets in terms of compliance, that gets even worse. But as you know, I was sort of like suggesting to people, because before we had low dose atropine, even on 1%, before we knew about low dose atropine, we were actually cutting down the 1%. And at the end of it, before we had low dose atropine, I was giving them 1 a week, and that would work sometimes, and that might be all you need. And sometimes you got 2 at the most at the end of when I changed over to low dose atropine. So and 1% atropine is readily available, I think, in most countries.
Yeah, you have any comments?
All my low dose kids are on actually in trials, so because I don't prescribe it outside trials, because there's no license preparation. But the close study is looking exactly that. So we're looking at 3 concentrations using a wide range of not myopia control, but oculomotor, pupil dynamics, accommodation, and all sorts of other factors to look at the equivalence of 0.05 versus more frequent lower dose ones, to see if we can create that equivalent sort of matrix for people to understand that if you can't get 0.05, this is the equivalent of 0.01. So we'll have those results by the end of this year. So I think that'll be a useful contribution.
Yeah. I also liked Audrey's presentation. Partially, she touched upon that even if you see the progression, you need to classify them into mild, moderate, and severe. Depending upon that, you can modify the options. And many parents and children, they believe that if you start on atropine or some other modality, they think they are immune from everything else and they can go back to their screen time, all that. So this is where a combination, I think behavioral therapy also becomes equally important as we start this myopia treatment options, either optical or pharmacological. So Mark, do you have any questions? And
let's move on with these. We've got some audience questions. We've had a couple of people asking about behavioral interventions or strategies. Somebody asked, do you believe in the 20-20-20 rule? If not, what do you propose? Qualified to that, is there any evidence that works? And what suggestions should we be given around regular breaks time? So somebody want to explain what the 20-20-20 rule is? I might get it wrong, so I'm nervous to do so.
I'm pretty sure it's every 20 minutes, look for 20 seconds, 20 feet away. And do I believe in it? No, because it has absolutely no basis in animal studies. If you look at the animal study interventions for lens rearing, what's impressive is that relatively short breaks, 8 hours of lens wear in an animal split up by 4 15-minute breaks completely blocks that effect. So I'm not a fan of 20-20-20, but I do think every 2 hours taking 20 minutes and explaining that 20 minutes from reading doesn't mean go on your phone. So I have every 2 hours, 20 minutes.
Any agreements, dissenting opinions?
Well, I think it's hard because what is near work and things, and I think the initial studies were on reading materials, and the question does it equate to sort of like phones and tablets and things like that. But for a better sort of like prevention, then we know it is helpful for probably the pre-myopes before they get it, and we try to do the interventions then. I think there are some actually, we've just been doing a review of it. There are some studies that do show that breaks do work and do help a little bit, and also increase light intensity. So usually now our sort of like recommendations, we could say outdoors, mainly outdoors, but indoors, just increase light intensity and take your breaks. Yeah. So that's what we suggest to our patients. But there is some evidence somewhere. But you talk about real life, it's really hard to do a randomized study on this.
Mm-hmm. So there's apparently a lot of discussion going on the YouTube stream about the one particular issue. Let me get this right. Can you clarify about the use of 1% atropine? Is that alone or is that in addition to low dose daily? So Ian, I think you sort of introduced the 1% issue.
That's just by itself. So I mean, Audrey says has come from 10 years ago and then went a different direction, and I'm sort of coming back from this direction, going backwards. So no, it's if you can't get low dose or it's unlicensed, then almost every country has a licensed preparation of 0.5 or 1. You just use that by itself once a week. My sequencing is just that I tend to do it as an add-on rather than a.
So you have the kid on optical, and then you add atropine if things are not going the way you like. Is that correct?
Yeah. So what's interesting is that there's good evidence that the MiSight lens, kids don't use the effective add that's built into a MiSight. But in fact, if you give them one with an atropine, they can read fine. So what I do in the clinic is if they're having either bifocal toric lenses or MiSights, which are my two lens solutions, I put in tropicamide in their eyes with their contacts in and see if they can read half an hour later. And if they can, off the door with the 1% once a week, and they're not going to come back and give out to me.
Yeah, so great tips. Ramesh, let's go back to these structured questions on the screen here. So when do you turn to other pharmacotherapies, and if so, what are they? And other complications with atropine eye drops, other than the obvious photophobia and trouble with near work. Anybody got anything to add on these two questions? Anybody using anything other than atropine?
Well, I'm not.
No.
Nope. Okay. So, and any other complications we need to know about? It's interesting. The American Academy of Ophthalmology report on atropine for myopia is absolutely silent on safety and risks, assuming there was nothing to discuss. But anything else we should be worried about?
So interesting, in African eyes, I'm not seeing, and majority of my patients are Africans and Indian, so they've got dark irises. And, I think it was Ian's, we had a couple of presentations that were, in terms of dilation, pupil dilation, photophobia. We're not seeing any of that here at all, even reading difficulties, even when my patients are using 0.05%, we're not seeing any of that. 1 or 2 patients, when we did 0.01% BD dosage, came in complaining about reading issues, but I've not had to put any of my kids into bifocals. So I know we need a lot more studies in African eyes. And obviously there's studies in different irises and different colors, but it'd be really interesting to see, what is the effect here and the complications. But as far as we've seen it pretty safe on our side.
Let's move on to final questions, and also we need to do some audience responses again, Ramesh.
One of the things about the complications I just wanted to bring in, we do have a large number of patients. The complications, what Zara said, like photophobia, dilatation, and some of them have reading issues, and very rarely they can also get into some kind of esotropia. We have some of those patients, but these are less than 3% of the patients what we start. It's a very rare complication in India. But one thing to avoid, we do that is that this happens in the first week or first month of starting. So generally, the new patients, we call them within a month or within 2 weeks, just to know that whether there is any complication. Just a teleconsultation or teleophthalmology, we do it. We don't bring them to the clinic. That's one thing we add to our clinical things. So the last question, Mark, what are the limitations of pharmacotherapy and how do you overcome that? Maybe quickly we can take one opinion and then we can move on.
I think we've pretty much covered this, unless anybody wants to add anything. Let's move on.
Okay, let's move on to the last part. This is the QR code which is available in the website, and you can take a picture of this, myopia consensus statement, which I said earlier. There is a parent and patient-friendly version, which is a small, shorter one. And now it is translated into many languages, what you can see here. It's very useful for the patient's education, and you can, as somebody said, their chair time can be reduced. Whenever you see a myopia patient, just give that, and then they can come back to you for further discussion. Last 2 questions. Please scan this QR code. The code is 81248774. That is 81248774. There are 2 questions. Based on what you have learned today, how strong is your understanding of the latest treatment options for myopia management, including atropine and behavioral modification? Very strong, strong, moderate, little, or no understanding. That's number 1. And the last question is, how significantly do you believe what you have learned today has improved your ability to manage myopia progression in pediatric patients in your practice? Very significantly, significantly, somewhat significantly, and there is no change. So I will just share these answers. So how many pediatric myopia patients do you see in your practice each month? About a third of audience today see 31%, and about a third see more than 50 patients a month. How strong is your understanding about the latest treatment options? Was moderate to strong for almost 70 to 75% of the people, and none of them had no understanding at all. So the last part of the answer is, if atropine is not available, what do you do? 48% of, close to half of the people, they go on to optical, and 26% they go to compounding the atropine. I think Mark has already said about this answer. And the last part of the question is, based on this webinar, how strong is your understanding? Very good to know that 76% of them had a very good, strong understanding. And how significantly do you believe your ability to manage? Significantly for 65%. So very significantly for 24%. So that's very encouraging for us to know. And the last part of 2 more slides I just wanted to share. The next upcoming WSPOS webinar is on August 5th, 2023. Very interesting topic about tips for surgical treatment of strabismus. What I didn't learn in fellowship. So it's very interesting. Please do join. And also we invite you all to Vienna for the WSPOS subspecialty day on Friday, September 8th, 2023. And we have very good myopia sessions with other sessions as well there. And lastly, for the next year, we are coming up with this physical meeting. WSPOS 5th is going to be in conjunction with Malaysian Society of Ophthalmology in Kuala Lumpur between 11th to 13th July 2024. And we hope to see many of you there, including all the panelists today. And I would like to thank everyone, all the viewers, and the fantastic faculty and the panel today who joined and made this discussion possible, and for their time on Saturday morning or Saturday evening, and all the administrators of WSPOS, and also the Independent Medical Education Group. Thank you so much, and have a lovely afternoon or evening or night. Good night, everyone. Mark, you want to say something?
Just a fabulous set of 5 presentations. Really in awe of the quality that we got today, and that really speaks to the responses from the audience about their enhanced understanding. So amazing job, people. Thank you so much for allowing me to participate.
Thank you, everyone.